Good afternoon, everyone. I'm Jonathan Bar-Said. I'm the president of the America-Israel Friendship League. And wanted to thank you, everyone, for joining this webinar organized by the America-Israel Friendship League, dedicated to hear from the COVID-19 front line. This webinar is part of our Friends Indeed campaign, a campaign that we are dedicated to help where we can as an organization, organizing activities, webinars, organizing activity-related webinars, basically to help shift the attention at home from the daily routine of isolation. Information webinars such as this one that are designed to educate the audience, as well as our weekly donation campaign, where our organization is making a weekly donation of Israeli sweets to bring smiles to children, as well as a thank you to the medical staff that are really putting aside their personal fears and concerns on a daily basis to provide the necessary medical attention at this time of need. I would like to introduce our moderator for today, Ambassador Dan Gillerman, chairman of the Israeli chapter of the America-Israel Friendship League. For many years, Ambassador Gillerman served as Israel's ambassador to the United Nations, two of which he also was a vice president of the UN General Assembly. In addition to steering the Israeli part of our organization, Danny is also currently serves as a senior advisor with Blackstone and sits on the boards of many major Israeli companies. Ambassador Gillerman.
Thank you, Jonathan, and welcome everybody. Thank you for joining this webinar. I must say that this is a very, very special moment for me because this is not just another webinar. The US and Israel are indeed the closest allies, have been for many, many years, forever. And at this moment, we are all in the same boat. We're all engulfed by this horrible pandemic. And we, each and every moment, think of our friends across the pond. The United States is very dear to us. It's very dear to me. As Jonathan mentioned, I spent 6 years living in New York, being Israel's ambassador to the UN. New York is like a second home to me. And when I see what is happening in New York and in the rest of the United States, I'm not just worried, I feel as if it is happening to my own home as well. And that is what makes this webinar, where we have the best minds and the best experts from both the United States and Israel, so very, very special. Just as an aside to our guests and webinar participants from the Philadelphia area and from Penn, I'm also a Philadelphia 76ers fan, but then nobody's perfect. But anyway, we're very, very fortunate to have with us today 5 great experts who hopefully will share their views with us and enlighten us on what is happening in their fields in combating, in searching for a cure, and in battling this horrible virus. Let me introduce them to you. First, I'll start with the Israelis, who are very close by. First, Professor Ronni Gamzu. Professor Ronni Gamzu is the Director General of the Tel-Aviv Medical Center, Israel's largest hospital, and he was formerly also Director General of the Israeli Ministry of Health. He's certainly one of the foremost leaders in Israeli health and medicine. We're very fortunate to have him. Our second Israeli participant is Danny Gold, who I can see very clearly right now. Hi, Danny.
Hi.
Danny is the Director of Defense Research and Development at the Israeli Ministry of Defense. He is widely recognized as, I don't know whether the father or the midwife of the Iron Dome project, which has protected Israel so incredibly well in recent years and has become our real shield. And he's now actually today really spearheading Israel's search for ways to battle, to combat, and to deal with the coronavirus, and searching for the most innovative ways to combat it. So we're very, very fortunate to have Danny. And Danny, thank you for being with us.
Thank you.
Our American participants are Professor Jill Barron. Professor Barron is the president of the American Board of Emergency Medicine, professor of emergency medicine, pediatrics, and medical ethics at the Perlman School of Medicine at the University of Pennsylvania. And incidentally, Professor Barron is also a recently recovered patient of COVID-19. So she has a very personal, unfortunately, but fortunately, she is well today, and she hopefully will share with us also some views about what it feels like to actually undergo and be one of the victims of this horrible pandemic. The other participant is Professor Max Newman, who is the director of the Emory University Hospital Acute Respiratory COVID-19 Intensive Care Unit, and Professor Lee Fleischer, who is chair of the Anesthesiology and Critical Care Department at the Perlman School of Medicine. He's also a senior fellow at the Leonard Davis Institute of Health at the University of Pennsylvania. So as you can tell, we have really the best minds and the best experts in the field, and we look forward to you sharing your views and your expertise with us. I'll start maybe with Professor Gamzu. And Ronni, we're very near. My home is probably 200 yards from the hospital, but we're very far and we haven't met for some time. I know you and your hospital have prepared well and feel very confident that you can deal with this epidemic, but it would be good if you could share with us some thoughts about where you are at this moment and how your center is prepared and on the battlefront of this pandemic.
Thank you so much, Danny, and thank you everyone for participating. And I know it's a very special time, and the worldwide event is really a mega scale, and any hospital and any community in the world is now dealing with it. So I'm looking at the situation in Israel, not only in my hospital, but also looking at the national view, because I'm, as director of, as once director of the Ministry of Health, I cannot help myself as looking and directing and trying to give advices for the nationwide project or the nationwide operation in Israel. So at the time being, in my hospital, we have about only 15 patients on ventilation, another 20 or 25 patients on moderate situation, and another 30 patients are on mild cases. We are now taking ahead and trying to move into our hospital some of the severe patients from Bnei Brak, from another hospital in Israel, Manei Yeshua, and to support them, because now in Tel Aviv, we have made us ready to treat 200 ventilated patients. The situation in Tel Aviv at the beginning of the crisis was, Tel Aviv was leading the country. But once the social distancing actions and the restrictions that the government has pushed forward in Israel, Tel Aviv has done a great job. The citizens of Tel Aviv changed totally. They were no more cynical and they were obedient. And now we have a very controlled situation in Tel Aviv. So now I'm giving support for Bnei Brak and for other cities in Tel Aviv in order to make sure that they will get the best treatment any patient that is in a moderate situation or is coming from moderate to severe or from severe to ventilation, any such patient has been giving in my hospital the treatment as an ICU patient. We are giving them the full support, no matter their age. Of course, we are challenged and ask for them for their view of how they want to prolong their life with these special circumstances when they are changing from moderate to severe. But we are giving them full support, and we have we had a situation that we were short in equipment for our staff and for the patient, but soon enough we have done within the last 2 to 3 weeks wonderful job as obtaining all what we need in order to treat our patient, and we are now ready now for 140 patients, and we can be ready to give ICU support for even 200 within a week if we will be asked to do so. So we were preparing ourselves from, I would say, the beginning of March, more than a month. Once we understood that the virus has invaded Israel, we understood that the doubling time is 2 to 3 days. This is the doubling time of coronavirus. So we made the calculation. We understood that social distancing is not in place at the time. It was in place in Israel really at the 12th in March, and unluckily on the 10th of March it was Purim, and people did too much close contacting and made the spreading going up. So nowadays, the situation in Tel Aviv area, in my hospital, is really under control. Of course, all the hospital is under another kind of operation. We have cut our elective cases by 70%, 70. We are trying to keep on the services that are really important. Of course, all the emergency services and all the oncology services and any kind of service that is regarded as a service that you must deliver no matter what's happening around you. Meaning our, let's say, pain clinic and institute is giving full-time services. And we're looking ahead of how to do that. Of course, our staff is all focused on treating our patient in the best way. We've prepared departments that will give the best kind of services, meaning not only managed by internists and anesthesists, but also on a logistic base, the department have been prepared to have a secure environment for our staff, our medical staff, in a way that if you have an aerosol, then we have a air system that will take the load or the droplet and aerosol load out of the air. And we've made so far 1, 2, 3, 4, 5, 6, 7 units. Each unit can contain 35 patients, 20 ventilated. So we are fully prepared. And we also made some kind of a change in the way that our staff is working. we have split them into capsules, allowing ourselves to have a protective kind of splitting that will allow us to have most of the team still in action if one of the team unluckily is, unfortunately has COVID-19. And we had such a case in a few departments. So this is more or less the way that we are acting. We are trying to transmit to the people of Israel, to our citizens, that we are under control. No one in Israel is going to need ventilation, and it's not going to be provided with ventilation. And we have done also a great job in providing more, tests, COVID-19 tests per population and we did many drive-in clinics, because we understand that one of the solutions and one of the things that one of the actions that we have to take is to provide more tests per population. So this is
okay,
more
Ronni.
situation in Israel.
Ronni, thank you. Thank you very much. And I would now like to cross across the ocean and turn to you, Professor Barron, Jill. If you could share with us really how are the medical centers preparing for the upcoming surge? Also maybe a comparison after you heard Professor Gamzu of different approaches being undertaken in Israel and the US, how the medical personnel are managing their own fears without compromising the quality of care. We'll be very happy to, or very interested to hear from you about how you view this and how you handle this in your hospital.
Thank you very much, Danny, and welcome, good afternoon and evening to the participants. Let me start by saying that emergency physicians train for this very moment. Part of our whole thought process and preparation is about being able to assemble ourselves into disaster mode and to respond to whatever situation presents itself, often with very limited resources. We don't often have the luxury of being able to have the top of the line response to every single patient, but clearly our objective is at the bedside to do whatever we can for any patient in crisis, whether it be illness or injury. So I believe that the emotional psyche of emergency physicians around the country is very much about an esprit de corps and a willingness to do whatever it takes. There are emergency physicians in academic centers as well as community hospitals that are highly participatory in national conversations with regard to the best way to do things. Many people have devised pre-triage systems. We're excellent in our skill set with regard to triage and prioritization. And in many instances, we are setting up tents and other venues with which to screen patients before they even make an entry into the hospital. So those sorts of systems are being devised. Also, utilization of telemedicine. This is a predominant form right now of urgent care or ambulatory care in the United States, and emergency departments are capitalizing on systems that are already in place for conversing with patients prior to them even making a decision to come to the emergency department. So our goal is to do some level of triage prior to arrival, and then once a patient has self-selected or has arrived by ambulance, we clearly then go through a further process of determining their risk profile for COVID-19. And those have been quite expanded from where we were perhaps even 3 or 4 weeks ago in this country, looking at only travel criteria and a very specific set of symptoms. And now we know that there are many, what I would refer to as atypical presentations. I think are not all that well characterized yet in the literature with regard to how people do present with this illness. So I think having a extremely high concern and level of suspicion for any particular person being a person under investigation is how we refer to it, a PUI. That is the way we are making the assumption that pretty much anyone who could walk through our door could be infected, and then therefore appropriately cohorting patients and taking the appropriate precautions. I would say when I talk with my colleagues around the country that most people do have personal fears, and certainly fears about infection control coming home to their families. Many places have provided shelter for individuals who don't wish to return to their families. So for example, being able to stay in hotels. I have many emergency colleagues who have chosen to do this. Nearly everyone is responding to the call for increased clinical time. I think the staffing ratios amongst emergency physicians and nurses have increased substantially with people being on backup call systems. I today sit attached to my phone with the possibility of being called in as an extra pair of hands. And so I do believe that it is a really all hands on deck approach. And, you know, hospitals vary in their willingness to discuss the supply chain. So I'm not going to comment specifically on any one type of hospital or system. But I think there is increasing clarity around what we need to do to protect ourselves. And I think probably Dr. Fleischer and some of the others will talk more about that in terms of greater high-risk exposures. From the national perspective, the American Board of Emergency Medicine has worked very hard to accommodate emergency physicians in two ways. One is we're looking at our trainees and the residents that are learning how to become board certified emergency physicians. We have granted them additional time if they should need to be quarantined, and we're not making it more difficult for them ultimately to achieve board certification. And in some cases, even consideration of graduating them early so they can be full-fledged physicians practicing and joining the ranks and don't need to be supervised any longer. And then the second way that we're really addressing this is to forego or delay or eliminate certain certification requirements for physicians so that they can feel that their main effort right now is directed toward a disaster response and a public safety net. I can certainly comment on my own personal experience, but perhaps you'd like to wait and give other panelists a chance right now to speak.
Right, thank you, Jill. We'll certainly come back to you because you have the misfortune or luxury of being the only panelist who has actually experienced this horrible disease, and we're very intrigued and curious to hear from you how you dealt with it. So I'll get back to you on that. I'd like to go back across the ocean now to Danny Gold, who is the only one among us who is not perfect. He's not a physician, but has an amazing code. And Danny, your real challenge is, you know, the R&D of this situation, and you're heading this on behalf of the Israeli Ministry of Defense. And we'd love to hear from you. What are the challenges that the security R&D can deal with and find solutions? How is the security R&D organized for the current challenges, and also in which fields, and how is Israel leading in breakthroughs in R&D, especially when it comes to this horrible pandemic?
Okay, hello to all. Thank you for inviting me. As you said, I'm now the head of the R&D in the Ministry of Defense and Israel Defense Forces. So I set our main goals this time to identify and adapt defense technology to provide diagnostic tools or clinical solution to meet the urgent challenges of these times. So I drafted all my experts in all disciplines, from artificial intelligence to sensor, robotics, even missile defense, Iron Dome, biology. We have some biologists who are the world leading expert in their field, not in the medicine, in the medical field, but they can do quick, effective R&D to urgent needs. Just like we do with the development of Iron Dome or counter tunnel efforts, we did the same. So we are now leading the National R&D Center for dealing with this coronavirus with many aspects, and we work together with of course the Ministry of Health, the Israel Innovation Authority, National Security Council, the hospitals, the patients, with all of them, with all the agencies. And in many cases, we leverage the virus technology and the manufacturing facility in the Israel defense industry, or startups, or universities, research centers, SMEs, that we already have some capability to twist them from robots, drone, radars to these needs. In other cases, we assembled several groups of experts who conduct many hours of meetings. Today, of course, most of them are virtual meetings, to brainstorm, to find quick solutions. And we also approach, by the way, with few calls for proposals for the public. You know, Israel is a startup nation, there are many ideas and groups for many suggestions. Till now, I think in few days, we got about close to 900 proposals from the public, from the expert in the public. And we take our unique capability to manage a large-scale research and development effort and bring together all the parties. I'll give you some examples what we are doing. Everything, of course, is doing with the hospital, with Helsinki airports, and all of this new process to us. We trying to find new ways to quick diagnosis, shorten analysis time in the lab, or do new kind of technologies that can diagnose very quick the virus. I can later elaborate with new methods, not the regular one, new methods, new sensors, which can be identify the virus in tens of seconds. This is our goal. For the equipment point of view, of course, we work on ventilators. So in addition to buying, of course, which is a lot of competition out there, we are changing, we pick small companies, we tie them to big defense company, and issue the very high-scale production line in Israel. So we twist Israeli Israel aircraft industry, Elbit and Rafael, twist the line from missiles to ventilator respirators, and they do it. Another field is, of course, sterilization and disinfection and high-capacity rate in outdoor or indoor. Of course, using the AI, artificial intelligence, machine learning, mainly to monitor and limit the propagation of the virus. Also to help the country, to help the policymaker to run the country. What area to close, what geographical area to close, what to open, how to do the policy, and these kind of things. We go also indoors, in the hospitals, in order to sense the proximity of medical staff and patient, to minimize the quarantine need. Today, of course, if someone is in the department is getting sick, half of the department, or maybe all of them, go to quarantine for 2 weeks. So we want to minimize it by using technology, sense who is going near to the hazard area, and then do some logical and intelligence according to need. And we go sprint events for quick R&D, sterile chambers, screening together with the expert for novel drugs, and of course, as said before, telemedicines, whether in the hospitals, when treating the patient or sensing the patient from standoff, not near, from standoff, from a few meters away, or from the other room, or even from a central location in Israel to area with the illnesses there. So this is what we are doing these days.
Thank you, Danny. Thank you. That's very exciting and very hopeful, and creates a lot of optimism for us here in Israel. I'd now like to turn to Professor Weinman. Max, now that you've heard both the experience in Israel's largest hospital and Professor Baron Gill's description of what is happening, can you give us your view and your experience, and basically, you know, what is happening in the medical centers, and what, you know, a comparison maybe even of different approaches being undertaken in Israel and the US from what you've heard?
So thank you for allowing me to speak, and I appreciate it very much. Look, it's a very chaotic and hectic time, but I'm very privileged to be able to work in the ICU at this challenging moment. I think I can relate to what is happening on a personal level within the units. We're currently able to go to a level of about 300 to 400 beds through the Emory system. And I think that the intensive care unit is a very unique environment. In fact, it's very much akin to being in a battlefield, as a number of other small areas in the hospital are, for example, the operating room. And it probably speaks volumes about the people that are attracted to that environment. And with all due respect to Dr. Gold, who I believe his background is from the Air Force, I'm personally drawn to the Navy, which says Titnadev L'Etgar, or volunteer for the challenge, which I appreciate. But in any event, I think what is important to realize about the ICU is that apart from the vast array of highly technologic equipment, it's the human factor that is obviously the most important, and that which defines who we are and what we do. I think that from a medical point of view, there are a number of issues that we face as clinicians. Probably amongst the most challenging is maintaining perspective. In other words, know what you don't know. And there is a lot we do not know yet about this virus, which is proving to be a very challenging opponent. And in light of that, it's essential to turn to colleagues when you recognize that you're in over your head. And within the ICU, you have to approach the situation in a very holistic manner. That is, deal with all the issues from nutrition to ethics to infection through to lungs, etc., etc. To focus on a single organ it will not work in this situation. The other thing is, in terms of perspective, is that things will never go as planned. It's not if they will go awry, but it will be inevitable. And sometimes many of us feel like we are those mechanical toys that we had as children, that you put them forward on the floor, they hit an obstacle, they bang their head, they reverse 180 degrees, and they go the other direction. It's imperative that we do not act reflexly, but that we act thoughtfully and very, I think, intensely about what we're doing. And what's important is that we approach things also imaginatively. Just as in Israel, every day there are new devices and ideas being proffered to various committees, various commissions, etc., etc. We've been working on new approaches to mechanical ventilation, new combinations of medication. I've been fortunate to be working with engineers to develop new devices to optimize lung function, which are non-invasive, new types of laryngoscopes, and devices that can ensure the optimal resuscitation of patients and also the safety of our physicians and nursing staff. And I think the other thing that is less palpable but extraordinarily important is that of leadership. And I think that many of us have recruited many young nursing staff and medical staff who are understandably so very anxious and very fearful about what their role is and can they in fact be harmed. And I think that in this unprecedented situation, what's imperative is that we lead in a way that we reassure them daily that they are not expendable, that they make a difference to us as part of, in terms of personally, as well as medically. It's utterly inadequate to lead from the bunker and have people do things that you are yourself not prepared to do. And I think that hopefully each of us reflect upon that every day as we're being judged by our peers and by the patients' families. But I think the issue of fear, which will be touched on by other speakers, is important in that we harness the fact that this is natural. It's absolutely appropriate when I have nursing staff or medical staff break down tearfully within my office and are very frightened for their own safety, are very frightened for the patients. It's imperative that we try to tell them that we are doing their absolute best and that we are imperfect and that there will be times that we will fail, not through lack of trying. And that part of the challenge that we're facing is creating a safe haven for our own staff where they can not only express their fear, but sometimes their anger at the fact that they feel a lack of power to address certain things, particularly the life and death of the patient. And together we promise the patients three things: that when they present to the ICU, people die. But we promise them that we will not allow them to experience pain. We will not do anything to undermine their dignity. And finally, that if we get to the situation that we are unable to help, we will still salvage that situation by making them as comfortable as possible and preserving their dignity. And I think that that is an aspect of compassion and understanding that we are trying to share with our patients and definitely amongst ourselves in terms of caregivers. And I think that the personal toll is particularly high in regards to this illness. There is, as in Israel, people are grasping at any hopeful message that we can give. And I think the most important one is that we are doing everything humanly possible within the scope of care that we can give. And that as decisions, more difficult decisions present themselves, we will preserve the dignity and of both our patients and our caregivers. And I think that's the main thrust of what we're trying to do within our current scope of care and practice.
Well, thank you very much, Max. And I must say that the issue of the ICU has attained, unfortunately, an added dimension with the hospitalization of Prime Minister Boris Johnson of Britain. The minute it was announced that he was actually moved to the ICU, the whole issue got a totally different dimension and a lot of worry about the situation. Obviously, I will not ask you from across the ocean to diagnose him, but I think what you said and your explanation, both about the staff and about the patients, and especially the addressing the fear and the dignity issue, are very, very important. Thank you. Thank you very much for sharing this with us. And Professor Fleischer, Lee, the fear issue was addressed, many other issues. I will not, present a specific question to you, but actually allow you to share with us your views about what you've heard so far, and especially your own experience relating to all these issues.
Thank you. Yes, it's pleasure, Danny, to be here and to be part of this. And good afternoon and good evening. The issues that we keep hearing in the U.S. is, will there be a ventilator for me? And even in New York, and we're radiating out from New York. We're 90 miles south, and we're starting to see in one of our more northern hospitals the issue of capacity. in the major centers, in the major cities, there are enough ventilators, and we have anesthesia machines we can even use in operating rooms, and we're prepared to do that in 2 weeks or even next week if needed. It's really the small hospitals and the smaller communities in the US that we worry about, where they don't have those capacities. But as was just mentioned, this issue of critical care, which I also oversee from the anesthesia perspective, we're looking where we can put all these patients. And fortunately in the US, our Center for Medicare and Medicaid Services created something called Hospital Without Walls, which Jill talked about, the tents that we're now allowed to put up, and putting ICUs into operating rooms just to be able to ensure that we can take care of all these patients. We're already hearing in New York that they are surging into these areas. And the fear of the providers is we don't have enough intensivists that was just discussed. There's only a limited number, so we're drafting anesthesiologists, surgeons, hospitalists, and we need to give them the education because they're worried about that. One of the things that was just mentioned that I think is important to address is this end-of-life decision-making. People need to really think about this dignity of if this is a very morbid condition, if they're in the critical care unit, we're hearing somewhere between 14 to 16 days on a ventilator. If they do need resuscitation, if they have a cardiac arrest, how far do you want to go? And I think that people need to have those discussions with some of their older relatives, knowing people's wishes. We have thought, and a number of ethicists, and I'm sure Dr. Barron can talk about this, sort of having separate groups give advice from those caring on the front line because of the stresses of directly caring for these patients. So it's really this idea of having the right equipment, having the people, but creating these teams of people with the right education. One of the things that we're most concerned about is being hijacked by people's negative emotions. Right now there's a lot of people talking, physicians and nurses take oaths of professionalism, and they want to go in there and they want to save patients. So right now, the positive emotion of being heroes, and you hear about what happens in Spain, you hear about the New York Philharmonic doing something to celebrate the physicians. But as time goes on, they'll be hijacked. There are newspaper stories in the Washington Post about being next to a nuclear reactor for the anesthesiologists and how to not have those take hold. And in fact, my colleague at Wharton, Segalbar, wrote about this in the Harvard Business Review, an article that we need to sort of stay positive as leaders, as was just mentioned. How do we make sure that troops don't get into disillusionment as they continue to take care of them? They're unable to talk to families, and families should think about how they want to communicate because our hospitals are closing their doors to anybody but the sick. And how do they have conversations with people they've never met in person? We've been thinking about this a lot. Segal and I are working on giving people a voice, thinking about asking them what are the emotions they're feeling and what can we do to help them through this time. So I think as we talk about this, I want to assure on this side of the Atlantic, at least in the large centers, we have those ventilators. The critical access hospitals are worried about it. And we are making sure our troops have our physicians, our nurses, respiratory therapists, the people who clean the room have the right education. But again, making sure that we give voice to those fears that they don't want to express, but they live with every day. And I'll stop there.
Thank you. Thank you very much, Lee. That was very informative and also very, very touching. You touched upon some of the most intimate and I think important issues which the medical profession is facing today. And in fact, relating to what you just said, and I hope, Ronni, are you still with us?
Of course.
Right. We have, we have hundreds, possibly thousands of people in this webinar who are asking questions. We won't have time to entertain or to answer all those questions, but I have a question here from Florida, which is actually a question which is directed directly at you. And it says, in addition to the critical clinical medical treatment your hospital is providing during the corona crisis, you recently took a very bold humanitarian decision to allow loved ones to spend time with dying coronavirus patients. How was that decision reached? And are you proud of the fact that many other hospitals, including but not only in Israel, are considering following your initiative?
I must say that it was like out of our regular operational way that we are treating patients, that we had the first people that were dying, and I had an approach, the family approached me that they were saying they want to say goodbye, and I was saying, okay, let's do that. And my staff was saying, hey, but it's not a regular way in Corona. And one of my management was saying, Ronni, let's be the first. And I was saying, obviously, why not? Because it's only giving them the protective measures and then allowing them in. And this is really very plain, and this is what you should do. And I think it's these epidemics, there is some kind of an anxiety, and then there is the issue that you do not have enough protective measures, equipment. And then there's the issue that maybe the families are also infected. And there is the issue that everybody is focused on treatment, and everybody is focused on surviving. Everybody is focused on the stability of your healthcare system, and everybody, and the situation is moving very fast. You're only 2 months in this, event, and people are not sitting down and taking decision calmly and understanding what's should happen, what is the logical way to take actions. So this is what was going on here, and then we write the way to do so, and we touch every single item, and then we had 2 or 3 cases that we were doing so. We sat down after that, and we had all the feedbacks and what we did right and what we did wrong, and then we revised it, and then we were asked to send it to the Ministry of Health and to other hospitals in Israel, and of course to other hospitals abroad. And Corona has a lot of challenges. This is one of the challenges, and we should keep on having moral values in the way that we treat our patients, and there's many other challenges that we are facing with the coronavirus disease. We have to be agile. We have to think 1-3 weeks ahead, and then to change our dynamics, to change our operation, and then to rethink, and then to revisit, and then to look at our plans, and to align again the way that we are operating. And this is one of the items. Thank you.
Thank you, Ronni. Jill, I'd now like to turn to you also, first and foremost, because you are the one who can actually tell us what this is really like and how it feels from a patient's point of view. But we also have a question for you from California. which would relate to that. And it says, as someone who has recovered from the sickness, are you in a better position than other medical staff to treat patients? Are you now not at risk? And will that allow you to treat patients with less concern of contamination?
Yeah, I'd be happy to describe my own personal clinical story with COVID-19. I was diagnosed with the non-rapid test on March 18th, but I had actually been experiencing symptoms for approximately 8 or 9 days prior to that. I had done some work-related travel through various airports in the United States, and I had contact in the emergency department. And as I mentioned previously, we were in a very different universe even a month ago. So some of the criteria that were being used and applied in terms of screening and isolation were not what they are today. So I at first had a series of symptoms that felt predominantly like a cold. I had some sore throat, some nasal congestion, but what really factored in very strongly was I had very significant pains, muscle pains, predominantly in my back. And at the time, I attributed them to just some over-exercise or mechanical pain. In retrospect, I see now that those were definitely a part of the viral syndrome. The first inkling I had that I was getting sicker was, again, as I said, about 8 days later when I developed a fever. I was prioritized for testing because I am a healthcare worker and I had scheduled clinical time coming up. So I was tested and it took about 12 hours for me to get the results. And then it began a series of days of fever, probably lasting at least another week, if not 9 or 10 days, which was accompanied by shaking chills, very significant fatigue and continued pains. And the concerns that I had were that I had chest pains that felt to be very much kind of behind the heart, as well as continued back pains, as well as pretty significant fatigue. And that began to unfold even more in the form of gastrointestinal symptoms, which ended up being probably my worst group of symptoms. So as the fevers got lower and subsided, I found myself with a very profound inability to eat or drink. I had abdominal pain, I had nausea, vomiting, diarrhea, and was really, it was a challenge to keep up with my fluids. I would characterize my entire course as moderate. Certainly I was not critically ill, but I was moderate, and I ended up having to make a visit to my emergency department for fluid hydration because I was, as I said, unable to really keep up appropriately with my intake. During that visit, I was noted to have some disturbances in my electrolytes, my chemistries in my blood because of the dehydration. And I was also noted to have some streaky, what they call infiltrates in my x-ray, indicating likely mild pneumonia, but fortunately my oxygen level was appropriate. And I think that is probably what caused me to have some of those chest pains. It very much felt like pain with coughing, pain with deep breath, but overall, fortunately, I didn't experience any decline in my oxygenation. I was released from the emergency department after about 6 hours of treatment. I very much wanted to go home. I was 100% isolated in my home. I have my spouse and 2 college-age children who moved back home, but had really no contact with them whatsoever in terms of interfacing with them or making meals or sharing the same spaces. So we were fortunate enough to have enough space to do that in my household. I would say the gastrointestinal symptoms lingered, and the total number of days that I think I have been symptomatic for was roughly between 3.5 to 4 weeks. And so it was really a challenging to overcome. I'm feeling so much better now. The recovery happened quickly. I was not tested again, but I was cleared by employee health to return to work because my symptoms have gone away. I do have some concerns that my cardiovascular conditioning is decreased. That may be coincidental with just being in bed for a long period of time, and hopefully that is not related to any long-term pulmonary effects of having that mild pneumonia. So again, I would characterize my illness as being moderate, certainly not severe, certainly not mild. It was frightening. I expected all along that I would become infected given my role as an emergency physician. And obviously, needless to say, I'm very happy that I'm now on the other end of it. You asked about what does it mean in terms of returning to work and what can I do? I feel incredibly empowered to get out there and roll up my sleeves and do as much as I can for other people. I will still take the recommended precautions. I think it is clear that people do have immunity. The extent of that immunity, I think, has, again, yet to be well delineated in the literature. And there are studies going on now that are measuring antibody levels in people's blood and what kind of response they've had, what kind of immune response. But I do plan to be actively engaged in patient care as much as I possibly can with my colleagues. And I will certainly participate in any donation of plasma or antibodies should it, be needed. If there are any clinical trials, I'm actively investigating how I can play a part in that.
Thank you. Thank you very much. And we wish you good health. And thank you for sharing your personal experience with us so vividly. And we do hope, just a very quick, you know that you're immune. You're quite certain about that. The literature or the science confirms that once you've had it, you're actually immune?
Well, I think both from a common sense standpoint and what we all learn in our medical training is that the body makes an immune response. And so to me, there would be no reason to assume I wasn't immune at this point in time. What happens many months down the road in terms of how different viruses can morph and change and develop different patterns, like we experience with influenza, that's another story. But I certainly consider myself to be immune at this time, even without formal testing.
Right, thank you. Thank you very much. We have a question here for Danny Gold. If you could maybe, be quite brief about the answer, because we are nearing, I think, the end of our time. Unless we can continue, I leave it up to Jonathan to let us know. But there's a question here which actually asks whether there is cooperation when you described all the research and the work and all the different entities that are taking part in that effort. Are the US and Israel actually working together on this?
Yes, we started a while ago to talk with various agencies in US or even cities in US. Everybody is busy with their own problem to get the fires off, but we are in a close contact with a few agencies in US, and we are trying to share knowledge, experience, data, and even technologies.
Right, thank you, Danny. And there's a question here also for Lee. Do you think that anxiety has actually increased the spread of the virus? Is that a factor?
No, I actually think people are more aware of social distancing. And I think that we started wearing masks about a week and a half ago. I saw, I think it was Danny, when somebody walked in, put on a mask. So when we're in people's presence, the idea of masks is helpful.
Right, thank you. So you think that actually because of the anxiety, people actually being more careful and observing the mitigation and social distancing?
One of the things we've always worried about is that people will go in and their anxiety will make them work faster and make mistakes. So that's the negative part of anxiety. We're hoping, and we do a lot of buddying system, where somebody is actually watching you don and doff all these PPE. So yes, it can make you more aware of the issues. It can make you make mistakes, but that's why we're creating buddies to overcome that part of the anxiety.
Right, thank you. Thank you very much. There's a question here also for you, by the way, but anybody else, maybe Lee would like to weigh in on this as well. It's a question actually from Atlanta, Georgia, which says that Georgia has been a bit late to the isolation than other locations in the United States. What is Atlanta doing that it might have learned from other locations that will make it better equipped to deal with the upcoming surge? I don't know whether any of you are really
Well, I'm in Atlanta, so maybe
Yeah,
I can
yeah.
help with that. I think that the question is absolutely a reasonable one. I think that, as everywhere else, social distancing is very active right now. Atlanta's always been notorious for having the most abominable traffic, and right now that is not the case. The streets are very empty. There is always a subgroup of people that require re-emphasis of the fact that this is a serious condition and that social distancing is the manner in which it is most appropriate. Those areas are predominantly outside Atlanta. Emory is working, as is Georgia Tech actually, and the remaining hospitals are working extremely diligently to emphasize points being raised by the CDC, which is being sensibly, behaving sensibly socially, not participating in large groups. Sanitation, hand sanitizing is imperative. The use of masks is now advocated. The public arena in which people gather and usually aggregate, such as restaurants, theaters, everything is shut. It's literally a case of you can shoot a gun in the middle of the street and no one will notice because no one's there. So I think that Atlanta is actually working very hard, despite the fact that no one has been perfect at all in terms of starting the race. I think we're moving forward very much. And the other very important issue is that of the transmission from patients that are asymptomatic. That's been a very important issue and one that needs to be emphasized time and time again.
Danny, if I can just mention one of our concerns, and we are in a slight lull here in Philadelphia in that it's stable, but they saw that in New York, they saw that in Seattle, so we still are expecting an uptick. But with Pesach and Easter coming up, we are concerned that people may ignore those social distancing, and as Max just mentioned, the asymptomatic patients, that we may see an uptick in 2 weeks or in a week from now. So people should really love to do Seder with my kids, but if they're not living with us, it's going to have to be virtual.
Well, it's interesting you should mention that, because actually in Israel, the minute we started this webinar, which is about an hour, just over an hour ago, Israel has been under practically total curfew. Nobody is allowed to leave their home. I mean, the biggest fear also in Israel was that people will not resist the temptation to have Seder, which is such a traditional night for us all, together with our families, and would go to the suburbs or to other cities. The police are actually policing the highways and the roads. Every car is stopped, and people are actually not just under lockdown, but literally from 7 p.m. today, which is like noon your time, until Friday morning, Israel is actually under curfew, exactly for the same reason, because as Professor Gamzu mentioned before, we had a big wave of infection and contagion during Purim, which is a big holiday in Israel. People ignored the recommendations and had big Purim parties, and contagion took off. And we're actually seeing today the results of what happened in Purim. We don't want Pesach to be another Purim. And our Prime Minister actually yesterday did say, he said, remember, Pesach is not Purim. Maybe also because it's not a Purim spiel and it's no game. It's a very serious matter. Let me ask you, and whoever of the very esteemed panelists would like to answer that, a question, and that is, your president has been advocating and promoting even, I would say, a certain drug. I think it's a hydrochloroquine. I don't think he pronounces it right. So I'm not well equipped to pronounce it exactly, but he even mentioned yesterday that he spoke to two significant pharmaceutical companies and had their people in London suggested to the team that is taking care of Boris Johnson. I mean, are we at any point near to a therapeutic drug, to something which has in any way been proven to be effective, whether it's this one or another one? Are we anywhere near a drug that could be a miracle drug for this horrible virus?
I'd only say I'd take Fauci's comments much more seriously. And he does not think we are there yet. I'm not hearing any evidence. I don't know if Max is or Jill.
No, I think, yeah.
Well,
no,
to those of you who value Anthony Fauci's advice, I recommend you read David Remnick's article in the new issue of the New Yorker, which I think came out today. He has a very interesting comment there about how Fauci feels about the president's comments. I hope he'll still be there at the next news conference.
In relation to what Lee said, I seem to agree. I think the strategy is multifactorial. In other words, I don't think a magic bullet is about to emerge, sadly. I think that there will be strategies that try to target the virus in combination, very much like the approach that targeted the HIV virus in terms of the manner in which we treat that. Of course, we're also trying to treat associated illnesses that can be found with it. I mean, flu is still present. And so we're treating patients what's known as empirically, in other words, based on how they respond and through some degree of trial and error. One of the big challenges we face as clinicians is dogma, and dogma based on inadequate information. And quite sadly, dogma is actually the compass or the sextant of the ignorant. And one thing we have to do is we cannot obsess about information that is lacking in data. We have to be very diligent in not pursuing tangential things that are based on rumor. And when your families present to you in the ICU, for example, I've had patients saying, I want my mother to receive an infusion of silver. I had no idea that the woman was at risk of becoming a werewolf, but the fact was that they presented a lot of naturopathic information, which has relevance, of course, but again, you've got families as well that say, I demand that my mother receive hydroxychloroquine. Hydroxychloroquine is not a benign agent. It is not as safe as people would have folks believe. And we have to be diligent in our scrutiny and our criticism of these so-called panaceas, which can be, unfortunately, come back and bite us if we pursue it so aggressively.
I would agree with both of those interpretations. I think we have to realize that the speed with which articles are being released in the peer-reviewed medical literature is unprecedented. And that means that we are getting people reviewing articles that are oftentimes very small numbers of patients, things that we would never accept under other circumstances in terms of their robust conclusions related to statistical methodology, or even study design. So I think we have to be very careful. That's not how we typically do business. We wouldn't want to lower our standards in terms of drawing conclusions from scientific articles that do not meet the grade that we're particularly used to. I had a number of physician friends who called me up when they knew I was ill and said, you know, you should just quickly get someone to write you a prescription and go to the pharmacy and fill it for hydroxychloroquine and azithromycin. And I was steadfast. I resisted it. I never once thought that I should do something like that based on, you know, a very poor base of evidence. I think it's something we should explore. We should pull out all the stops in terms of looking at therapeutic options, but I think we have to be very cautious, as the others have said, about just assuming these treatments automatically work without proper vetting.
Well, thank you all. Thank you very, very much. I think this has been very incisive, very informative. In a way also leaves us with some optimism about the future, especially seeing what great minds and wonderful people are actually dealing with this. I think you're all really a testament to the excellence, ingenuity of both the United States and Israel. And I thank you for sharing your views, for taking the time at this very difficult time. And I wish you all a very, very happy Passover and a very happy Easter. Hopefully it will be the start of maybe seeing the dawn and getting better news and having happier and better days in the future. I wish you and your families really good health. Be safe, be well, and stay home. And thank you very, very much for your very incredible and very, very real contribution to this conversation. Thank you, and happy Pesach, happy Easter, Chag Sameach to all of you.
Chag Sameach.
Thank you very much.
Chag Sameach.
Excellent.